we often do an angioplasty where we have a anatomically beautiful result and a corresponding nice clinical, examination afterwards with a soft thrill, and we're happy and proud of ourselves. We got a great result, and then 5 minutes later, the thrill is gone.
The challenge when we see recoil greater than 30, 40, 50%, we're really not getting an adequate response out of our angioplasty. Many times recoil is also under-recognized. We may see an immediate nice result post-angioplasty. However, most of us don't spend much time after the initial angioplasty imaging the patient.
Once the angioplasty balloon effaces the lumen to the degree that we want, once that's released, the recoil occurs when the lumen goes back to its stenosed diameter or even smaller.
And it's not uncommon that the patient's still on the table at that point for some reason or another. Sometimes we wait on purpose and we re-examine that lesion, and lo and behold, it looks worse, much worse than it was 5 minutes ago after we completed the angioplasty.
So I think identifying recoil is really key, and oftentimes it's underappreciated by the interventionist in the busy lab. I think going back to your physical exam is key. After angioplasty a lesion, I always go back and I feel the graft. I feel if it's still pulsatile, if we have an improved thrill. And the physical exam also can be helpful in recovery if you don't have a Doppler ultrasound easily available. Really, physical exam findings can many times give you a key whether you're dealing with significant recoil or not. Going back and treating it again with angioplasty, we know that outcome is not going to be ideal. The next step would be perhaps a larger angioplasty balloon. However, the larger you get, the more incidence of rupture you may develop.
Once you have that repeat angioplasty and the fact that there's recoil, you're causing more endothelial damage and therefore a greater risk for future recoil and restenosis. So for me, it's a bit of a warning sign.
And sometimes these patients come back and sometimes they don't follow up for a year or two. And when they come back, you'll find an occluded segment. And then when you have that occluded segment, now you have a bigger problem.
And in our eyes, the best management for this is the use of a stent graft.
Physiologically, it makes sense to have something placed that will prevent that rebound or that recoil. And a stent graft is something that provides that scaffold so that if it rebounds back against something to reduce the ability for it to go back to its original stenosed luminal size.
And at some point, you may actually just need the scaffolding and support that the Gore Viabond endoprosthesis can provide to give you a more durable response at that graft vein and anastomosis junction.
You want to prolong the life as much as possible by using the Viabond stent. And that helps out a lot with this elastic recoil.